To think that dying is failure is going to colour everything that you do.
Resuscitation for those with hearts too good to die has been a success story, but pioneers never intended that CPR be applied to all patients in all settings.
What has happened is that we've got into this sort of pattern of resuscitating anyone and everyone, whether it's in their best interest or not.
The fundamental problem is that a lot of the interventions that we commonly use in medicine have been developed on a single issue or a single problem.
Patients are dying more commonly in hospital with chronic conditions that respond less well to treatments. Doctors may not identify the trajectory the patient is on or discuss with patients about end-of-life issues, including resuscitation. In hospitals, the default position may not be appropriate.
Have we confirmed cardiac arrest?
Yes, we have.
I see MET calls frequently where no end-of-life decision has been made, despite the fact the patient is on a deteriorating pathway.
We delude ourselves into thinking that we're good at this. We actually aren't.
Patients have a very falsely high expectations of resuscitation.
I think we all have a role to play.
At the moment, there's probably a lack of consistency and a lack of across-the-board consistency with how consultants approach these discussions and conversations.
The main problem is us.
Doctors have not been well trained in making or communicating these decisions.
Oxygen away, charging, top clear, middle clear, bottom clear, I'm clear, hands off compressions.
Okay, we're still in a systole. Can we dump the charge?
Dumped.
And can we continue with CPR?
Doctors and clinicians struggle with conversations, particularly these difficult ones.
If your heart stops, are you wanting us to start it up again?
Of course I do. Of course I do. Yeah.
This can be improved by applying a consistent approach for those whom are not in the default position. It's time for a framework to guide assessment and communication with a patient, family and carer.
If the patient can't survive CPR, then we should not be offering it.
Identifying patients who won't survive CPR, it's not black and white. Most of the research has been about how to do it and the technical aspects, not who to do it on.
A decision about CPR is embedded in a discussion about your life, your values, your illness, your expectations, and is part of an ongoing conversation.
You can't discuss CPR without discussing life and death.
And we could do with a lot more consultant support and guidance in this area.
Okay, can we please remove all the monitors? We'll need to pronounce this lady dead.
Communication is a learnt skill. As the cornerstone of medical care, all doctors should strive to improve their communication. This can be achieved through reflective practice, use of tools and workshops.
I'm a bit worried that your breathing isn't getting better the way that we would expect.
Well, yes, but it's been like that before. I've bounced back, gone home, seen the grandchildren.
You know that you've achieved something when you actively listen to the other person and that they feel actively listened to.
Well, I do know it's getting bad, but how far? I don't know. What do you think? What can we do?
They need to be able to trust that we have their best interests at heart. And for CPR, they also need to be able to trust that if they have an order to withhold CPR, that we still will provide high quality care, and that doesn't mean they'll miss out.
I kind of know deep inside that this is happening.
And they're much more likely to make decisions that are in their own health interests and have a good outcome, a good experience of healthcare, but also a good death if their time is up.
If the family has had the discussion, if the level of understanding and knowledge is high, then you'll find that you have extremely strong support and strong advocacy for making your decision.
Videos, resources and a facilitator's guide are available to support educators.